Well, good morning, or I should say, I think it's a good afternoon. It's been a fantastic morning. I think you'd all agree with me. The opportunity to hear from our fellows, our researchers, practitioners, young adults, elected officials, and even Carly and the folks at Sesame Street. What can I say? I'm really energized. I must admit, I have a three-year-old, not so new, granddaughter, and I'm re-experiencing Sesame Street, and it's a real pleasure. They do a great service to us all. Today, we acknowledge the power that Mike Bloomberg's gift is making across the country. These impacts have transcended the walls of Johns Hopkins and are resonating in communities where residents and local organizations are fighting for change, where critical research is underway, and where the lens of public health has begun to provide new perspectives on some of the most challenging health problems we face in this country and indeed around the world. Last year, the Bloomberg School launched its 5-year strategic plan called The Power of Public Health. That plan focuses on the power of education, science, partnerships, people, and advocacy to advance health for all people. Now, to bring this power to bear to help millions of Americans, we must mobilize evidence. We must enact new policy and work towards equity. And it is no coincidence that these principles, evidence, equity, and policy change, are the cross-cutting themes that help guide the work of the Bloomberg American Health Initiative. And they are particularly relevant to the issue of maternal mortality, the focus of our next panel. From 1990 to 2015, while global rates of maternal mortality declined by 44%, the maternal death rate in the United States increased from 17 deaths per 100,000 births to 26 deaths per 100,000 births. And in case you missed that, let me say it again. Over the past 25 years, the maternal death rate in the United States increased from 17 to 26 deaths per 100,000 births. Outcomes for women of color in the United States are especially grim. Black women's mortality is 3 to 4 times that of white women, and American Indian and Alaskan Native women fare worse as well. Now, making progress requires looking the problem right in the eye. This means tracking the rate of maternal mortality, measuring the rate of race and the rates by race and ethnicity, and assessing the data and critical adverse events like hemorrhage, and even monitoring results by hospital. Yes, that's right, by hospital. So I'm excited to introduce our last discussion of this incredible day, which will cover how public health researchers here at Johns Hopkins have teamed up with public health leaders in New Jersey to use data to drive change and ultimately to save mothers' lives. Please join me in welcoming this terrific panel. Thank you.
Please welcome our panel on How Does Data Spark Change? New Jersey's Maternal Health Hospital Report Card, moderated by Josh Sharfstein, and panelists Andrea Creanga, Judith Persichilli, and Stacey Stewart.
Well, this whole morning has been about the power of public health and how it can work in so many different ways to improve lives. And we're going to go to a really important issue and a really specific example, maternal mortality. So I'm going to ask you, Stacey, first, as the leader of the March of Dimes, to talk about the crisis of maternal mortality and why is it really important for people to be looking at New Jersey?
Well, thank you for this, and it's really great that we're having this conversation, and I think the statistics that everyone just heard are pretty appalling and pretty shocking. A lot of people are still really amazed and baffled and really shocked by the idea that the United States is among the most dangerous developed nations in the world in which to give birth. And the fact that we have seen an increase in our maternal mortality rates in the US while just about every other major developed nation has seen a decrease is really, I think, unacceptable. And that's a lot of what we're focused on at the March of Dimes, working on healthy moms and healthy babies. And I think it really is important to look at this issue both at a federal level, and certainly even this week there's, fortunately, maternal mortality legislation that is being marked up on the Hill, which is good, following some really important legislation at the end of last year, the Preventing Maternal Deaths Act, that really helped to provide more funding for maternal mortality review committees, which New Jersey does have. But I think what New Jersey is doing is really a step ahead in many ways. If you haven't had a chance to look at it, and I had a chance to do a deep dive just a little while ago into the report card that they've done, what New Jersey is really doing is recognizing that this issue of maternal mortality, there's no silver bullet answer to it. There are many issues that are contributing to the issue, but I think one of the things that they're doing is starting with the idea that unless and until we collect really smart data and really have an opportunity to, at the hospital level, at the community level, design appropriate interventions based on what we're learning, we'll never really get at the answers, because the issues and the factors contributing to the problem in the first place are very complex.
I heard you speak about this before, and you talked about accountability. It wasn't enough just to recognize the problem, but people had to feel accountable for that. Would you just
I think feel accountable, but also feel like they're, I think part of what happens is when all this data comes out, people feel very attacked, and they become very defensive. And I think what we can't afford to do is put people on the defensive that keeps us from getting to solutions. So I think one of the things that happens with accountability is also we need to really look at what are the systemic fixes that need to be in place to help healthcare providers, help hospitals, immediately address the problem and know that there are solutions that they can pursue, whether that's through improved implementation of safety bundles, better training for healthcare professionals. But yes, accountability has to be at the core of everything, because this is an issue that is affecting the lives of too many women in this country, especially women of color.
So let's get to what New Jersey has been up to. Commissioner Persichilli, why don't you tell us the story here?
Thank you. Well, first of all, I want to thank you for inviting us here. I also want to thank Dr. Creanga. She was our technical assistant in developing the report card. I also want to recognize that we are between you and lunch, and it's been a long morning. So I just want to make sure, particularly for the fellows in the audience, I'm going to ask you to focus on two bundles. The first bundle is emotion, desire, and knowledge. The second bundle is payment reform, regulatory reform, and transparency. Transparency fosters accountability. So why did we start the report card? Why did we end up having a report card that is so granular that it not only looks at all of the complications and compares statewide data, hospital to hospital, down to differences and disparities of race and ethnicity?
And you don't do hospital A versus hospital B, you name the hospitals.
Every hospital is named. So why did we do it? Well, in 2017, there was an article published by ProPublica along with NPR. And the title was something like, "This was the last person you would expect to die in childbirth." And it was about a hospital in New Jersey where a 33-year-old NICU nurse at that same hospital, married to a physician, died within 24 hours of delivering her first child because no one listened to her saying every hour, over and over again, "I don't feel well." Emotion. It caught everyone's attention, and not in a good way. So how did we take that emotion and move it to real action? Well, we needed the legislature. We needed the legislature to step up and say this should not occur, and it should never happen again. So how do you get the legislature to do that? You just get a group of upset, angry women. And they worked for the Senate. They worked within the legislature. And the legislature wrote 12 bills, one mandating an annual report card.
Now, to get that to work, you have to make sure the data is accurate, that it's fair, and that you can put data out by hospital. And that's where Dr. Creanga comes in. You were just minding your own business. Is that true?
And then we called.
Yeah. So explain what your role in this was.
Sure. So this was a process that started about a year ago, and I was actually asked to provide technical assistance on getting the data right. And it was data on maternal mortality first. We wanted to make sure that we capture all the deaths. We wanted to make sure that we use all the data sources that exist out there, and that we put a process in place that is consistent and can be used throughout the future iterations of the report card. So making sure that we have the right data and the right processes to identify and review the death. And then on the morbidity side, we are looking at pregnancy complications, and we are looking to make the data comparable between the hospitals. So making sure that we adjust for the type of complications or the type of chronic conditions that women enter the pregnancy with, which is a burden to pregnant women. And we wanted to make sure that we adjust for those differences in the patient mix at the hospital level, so that we compare apples and apples when we're talking about the hospitals.
So now you have the data, and all the hospitals were basically the same. Is that right?
No.
They weren't. So talk about what you found when you actually ran the data.
Well, I think the simplest explanation were C-section rates. We had a low of under 20% to a high of 47.9% C-section rates. Truth be told, the data was by the time we got it out, 2 years delayed. And some of those, the 47.9% had decreased their C-section rate to just under 30%, still too high. But the differences were startling. And the differences on a broad level were startling because we found that some safety net hospitals, urban environments, were actually doing better than some affluent environments, which was kind of interesting to us. But the data is so granular, as we peeled away the skin of the onion, the disparities were alarming. And that's really something that we need to focus on going forward.
So how have the data been used to improve maternal health care in New Jersey?
Well, the first thing is the CEOs all received an embargoed report card. So they had like a weekend to think about it. And I was one of those CEOs at that time. I was working at University Hospital in Newark, and I got the embargoed data. So what was the first thing I did? I tried to discredit it. Yeah, this is old data. This can't be. But then I looked at our C-section rate, and we were one of the best in the state. So I started saying, well, maybe this data's not that bad. Yeah. I could continue looking at this. Dr. Apuzio, who was the head of our obstetrical service, actually is the chair of the second oldest maternal mortality review committee in the United States, which is in New Jersey, which has been going on for a long time. So obviously I met with him, and he said, this is real data, and this is granular, and this is going to help us. Well, the question is, in what way? And our next step, actually, is to bring together, and this is by regulation, a maternal review committee that will develop the particular protocols that every hospital will follow. Well, why would they do that? Well, we now have a governor and a first lady who has made maternal health at the highest point of their agenda. The First Lady, Tammy Murphy, has gone on record as saying, New Jersey will be the safest place to have a baby. We will be the safest place to have a baby. And when your governor and the First Lady says that, 39 of the 49 birthing hospitals signed a pledge that they will be the safest place to have a baby.
The other 10 are looking over their shoulder.
Right.
And so when you look at this
Yeah.
from your perspective, which is national and even global, what are the lessons you see, or what do you see out of New Jersey right
So
now?
I think the report card is really and it's a really necessary first step. And again, New Jersey is the only state that I'm aware of that's doing it at the level that they're doing it. So kudos to New Jersey and the leadership in New Jersey for getting this done. I do think, though, what some of the things that New Jersey is doing to go beyond it are really getting at some of the root causes. So, you know, one of the things that CDC has said is that of all the cases of maternal mortality, about 2/3 of them are preventable. 2/3 of them shouldn't even be happening in the first place, are pretty much easily preventable, right? With better care implemented at the time of pregnancy and childbirth. About half all the deaths happen between the time of childbirth or pregnancy up to about 42 days after the baby comes in New Jersey. You know, part of what we know is that if we can provide better care immediately, recognize the warning signs, stop delayed and misdiagnoses and things like that, we can actually do a better job. In some cases, just looking at the data hospital by hospital allows us to know which hospitals need additional help, which of them may need additional training, what are some of the underlying causes and issues. But I think what New Jersey is also doing is doing some other things, like looking at reimbursement for doula care, where we know so many women of color report that they don't often feel respected and heard by the healthcare system. They're looking and yearning for alternative sources of support and help through pregnancy and through the childbirth process. Looking at ways to deal with the fact that we have what we call maternal care deserts in the United States, where 35% of all counties don't have hospitals that offer obstetric services, don't have one OBGYN, don't have one certified nurse midwife. So we have to make sure that there are transportation support services and ways for women to get to the care that they need during pregnancy and at the time of childbirth and even afterwards. So one of the things that New Jersey is doing is looking at all of these things around doula, transportation services, Medicaid coverage for group prenatal care, which is an evidence-based program that has been shown and proven to reduce the rate of preterm birth and actually improve maternal health. I mean, when I look in New Jersey, I look at sort of the beginning of a model of what a state needs to do to be all in on this issue of improving maternal and infant health. The last thing I'll say is that we need to make sure that we're looking at this issue of maternal and infant health. We don't just have a maternal health challenge and crisis in this country. We actually still do have an infant health challenge as well. Preterm birth rates are on the increase for the 4th year in a row. Black women are 50% more likely to have a baby prematurely. 72% of all premature births happened within the last few weeks of pregnancy, often due to maternal complications.
Maybe we'll start to see hospital-specific report cards about infant birth outcomes.
We would love to do that.
That's a thought that's occurred to some health officers. Yes. Okay. Well, I think this has really been fantastic. I hope that your phone keeps ringing as you hear from other health officers. And Dr. Creanga, I think we're going to have to get you like 4 lines on your phone. Make sure you can handle the different inquiries. Please join me in thanking this panel to talk about how public health tools can save lives.